Hello, everyone, and welcome to the webcast. I'm Sean Silkoff, technology and biotechnology reporter with the Globe and Mail, and I'm pleased to be your host and moderator today. Before we get started, I would like to acknowledge the Globe and Mail headquarters is situated on the traditional territory of the Wendat, the Anishinaabeg, the Haudenosaunee, the Métis Nation, and the Mississaugas of the Credit First Nation. We're grateful to have the opportunity to work and to live on this land. So over the next hour, we're going to talk about artificial intelligence, or AI, and how it is changing disease detection and diagnosis in healthcare. We have an excellent group here today to discuss the topic. If you have any questions, please type them into the Q&A box on your screen, and we'll get to as many as we can later on. I'll introduce our panelists now. First, we have Dr. Angela Genge, who is the Executive Director of the ALS Center of Excellence and Director of the ALS Clinic with the Montreal Neurological Institute Hospital. Next, we have Alice Williams, Board Member with the Wilson Disease Association and the Canadian Association for Rare Disorders. Alice is also a volunteer patient partner with the University Health Network. Also joining us is Ricky Mera, General Partner with Continuum Health Ventures and partner with NextMed Health. Continuum is an early stage venture capital firm in the health tech and longevity space. And last but not least, we have Dr. Valija Subasri, AI scientist with the Peter Munk Cardiac Center. Valley leverages AI for precision medicine in the cardiovascular disease space. So great. I'm looking forward to this. Welcome, everyone. Thanks for being here. Why don't we jump right in? So we've been talking about AI for years, but it's become front page news with the launch of ChatGPT in the last year. AI models can typically be split into two categories, discriminative and generative. But I'm going to leave the rest to the expert, which is Valley. Valley, I was wondering if you could give us a quick primer and overview on the current and potential applications of AI in the health sector, right from drug discovery all the way to dealing with patients in hospitals.
Yeah, absolutely, Sean. It's a big question. There's a lot of potential in this space. And so I focus a lot on precision medicine applications of AI. And what that entails is really tailoring patient management and care for each individual's specific needs based on their genetics, their lifestyle, and their environment. And so broadly, for healthcare, what this means is we can do risk prediction and phenotyping for early diagnosis and risk stratification to allow for better surveillance. For treatment, we can actually optimize treatment plans by identifying, which drug combinations work best together, what's the optimal drug dosage. AI can allow us to identify approaches to tackle negative side effects, to minimize these approaches when we do treatment. And another big area is this idea of using AI to model molecular representations to predict the properties of chemical compounds, which can actually be very useful for drug discovery and development. And so this is a really exciting area because, we have traditional modalities like EHR data, imaging data, but now with the cost of sequencing decreasing, we can do these AI-enabled precision medicine strategies that leverage molecular information and that also leverage multimodal data. So we're seeing kind of these larger databases come out where they have multimodal data sets like the UK Biobank that allows us to do these kind of risk prediction, phenotyping, predictive studies. Also with wearables, that plays a large role now. The ability to monitor vitals, activity levels, especially, we just had COVID-19 where there was that difficulty to see healthcare providers. So having these sorts of modalities really helps us take a holistic approach to precision medicine using AI. And now, like you mentioned, with this kind of new wave of generative AI, there's a huge use for things like large language models and even generative AI models built in this molecular space. So like protein, generative AI models, DNA-based generative AI models for generating new compounds that can actually be tested in the clinic. Also from an operational perspective, there's a lot of value. So like automating a lot of tasks like clinical documentation. So yeah, the role of AI in healthcare is really, really exciting.
Yeah, it must be. I can imagine someone like you, it probably think like you could spend your whole career just in AI in all sorts of areas of healthcare. Ricky, you would have probably a similar level of excitement, I think, from a slightly different perspective. You started as a bench scientist at the U of T, working on gene editing and disease modification and prevention, spent time as an analyst and consultant in the medical device and pharma space, and you launched a big data predictive health analytics company. Now you run a venture capital fund focused on health tech and innovation. Where do you see the biggest potential for AI in patient care and opportunities for companies to create patient solutions or create solutions to improve patient outcomes and maybe even help with caregiver burnout?
Thanks, Sean, and hello, everyone. Yeah, I've spent about 2 decades now with a lot of exposure both from academia and industry, and I generally believe we're at a revolutionary moment in medicine. In patient care specifically, look, I think, and some of this will overlap with what Vali just mentioned, but predictive analytics and preventative intervention. So, using AI now to predict health risks, stratifying patient populations based on susceptibility to diseases. I think this will have a massive impact on the existing healthcare burden, largely one that's been built up due to chronic disease development. And I think that will enable healthcare providers to intervene proactively, preventing the onset of progression of diseases and thus reducing the burden overall. A second place I think we're going to see movement is early disease detection and diagnoses. As an example, we're starting to see AI and imaging continuing to evolve at a rapid pace, from enhancing diagnostic accuracy to expediting medical imaging. We can now do like a whole body MRI in just under 30 minutes. This will allow us to detect tumors in radiology scans and abnormalities, even in digital pathology scans. I think this impact will allow for earlier detection, which will prompt intervention and significant improvement in patient outcomes. We're also moving towards personalized medicine and treatment. Vali talked about sort of multi-omics. We're in an era now where the cost reduction to capturing genomic data, epigenomic data, metabolomic data, microbiome, proteome, transcriptome is all starting to kind of come together. When we marry that in with patient records in the EMR and the vast amounts of medical literature that's out there, we can really start to tailor treatment plans based on individual characteristics. This will improve efficacy, reduce adverse events, and align interventions with the patient's unique biology. Patient engagement and education is also, I think, really important. With the growth of AI-driven consumer health apps, I think patients will be provided personalized health information, lifestyle recommendations, medication adherence reminders in near real time. Imagine your earbuds or your Alexa Google nudging you to consider changing the recipe you just looked up based on a specific output that your glucose monitor is reading out. This is about empowering patients to take an active role in their own healthcare, which will lead to better outcomes. So I think every one of these individually is going to matter, but I think the synergy of all these together is really going to have a transformative effect, and which will enhance overall healthcare delivery. Yeah, I think you talked a little bit. You asked about the second part of that question was around physician burnout. Is that right?
Mm-hmm.
If we quote the president of the AMA, somewhere between 1 out of 2 docs are claiming burnout. That's an astounding number. 1 out of 5 docs are claiming they might be leaving their practice in the next few years. This is not shocking. When physicians sign up for medical school, they're not thinking about all of the administrative burdens. They're not intrinsically going to med school so they can become, data entry clerks. So this is a real problem. I think keyboard liberation, as Eric Topol best puts it, is one of the first things that we're going to solve for as we start to see ambient listening. Within the healthcare setting, we can take the physician away from the keyboard, and so they can have a little bit more empathy and a little bit more face time with their patients. I think a recent Stanford study shows that docs spend more time in their electronic health record than they actually do with their patients. I think the other burnout piece is associated with the exponential amount of data that's being published daily. In the 1950s, if you were a newly trained doc, you can go an entire practice. You could retire before the medical knowledge had doubled itself. Today, and I kid you not, this is doubling every 70 days.
Wow.
So the best of the best doctors would never be able to keep up with that. And so I think this is where AI can sort of tame some of that data explosion. And we'll start to see, this natural conversations and ambient intelligence linking with the ability to summarize based on symptom inputs. We'll start to see this co-pilot effect that everyone's excited about. And for a subset of things, I think we may even start to see an autopilot. Longer discussion, but happy to engage on that as well.
Oh, that's great. Thanks to the two of you for sort of setting the stage for the opportunity. And I'm really glad that we have Angela and Alice to sort of bring us down to the level. I mean, why are we doing all this? Because of you. You know, the people who are receiving and putting into play all of the innovations. So, and let's start with you. Your work focuses on ALS and other neurological disorders. Everyone knows ALS is probably one of the most terrible diseases. I understand one of the challenges for doctors is that it takes a long time to diagnose. Tell us a little bit about what's involved and where that leads. And I have a follow-on question for you.
So thanks for inviting me first, Sean. This is a great opportunity to describe what's going on. In neurology in general, and in specifically in rare disease, the path to diagnosis starts with some symptoms that are often very benign, and are the first symptom may be common to 20 different conditions, and only with time or with the astute physical exam can you trigger the top 3 or 4 diagnoses you should consider in an individual. Because, for instance, ALS, and this could be a talk about any muscular dystrophy or any Parkinson-like syndrome, because ALS starts with the person feeling very well. They feel healthy, but they have a little weakness in their hand, or they have a little weakness in their foot, or their speech is not quite right. That triggers a visit to a family doctor, which usually, but not always, triggers a visit to a general neurologist. And that's where the opportunity is, because the general neurologist, if they've seen 4 or 5 ALS patients in the last decade, may think of ALS right away. But if there's anything unusual about the patient is very young, under 30, the patient is very old, either of those groups have slow paths to diagnosis. If the patient is otherwise so fit that the neurologist thinks of much more common things like a pinched nerve, then the diagnosis can be quite delayed. And where AI is really fitting in this project, which I can describe later, is really fitting in, is to try to help these physicians when they put in a set of symptoms plus components of a physical examination into their EMR, to have a pop-up essentially saying, have you considered? And with this signal, what we're really trying to do using AI is to trigger a rapid referral to an ALS clinic or an ALS expert, so that paths to diagnosis can be shortened down to a reasonable length of time. In certain provinces in Canada, it can be up to 2 years to get the diagnosis. So wow. If it takes 2 years to get the diagnosis of ALS, you essentially have missed the window for every currently approved medication plus every innovative medication. So what we would like to see is the diagnostic delay be somewhere around 3 months.
So I could see this being almost like, by using AI, you could take these electronic medical record keeping software programs that every doctor uses and infiltrate for thousands of rare diseases, and so right. It would almost like you're typing a symptom and a menu pops up, and maybe it shortens as you keep adding more symptoms. That's fascinating. Yeah. Tell us a little bit more about this project you've been working on then.
So that you've hit the nail on the head. This can be used for any rare disease, and we're really looking at ALS as like the poster child, where the need is so great, because the ability to treat is so short, that we want to get people early. So we've come together, we've partnered with a couple of different groups. We have an AI company, and I partnered as well with a neurologist at the Credit Valley Hospital in Toronto. I shouldn't say Toronto, Mississauga. That shows my Montreal bias. And we actually started the pilot project listing all the symptoms that we see as if you get them in a group, in one patient, they should trigger the thought that this patient may have ALS. Then we probed his data set, his EMR, and compared, given the list of symptoms and signs, we compared what diagnosis people eventually had to what we thought was critical to bring up ALS as a top line diagnosis. And then we refined it several times. And now it's out in the community across the country. We have 12 or 13 neurologists from the community, from BC all the way east, all the way to Nova Scotia, who have volunteered to have this algorithm put into their EMR, probe it, see how many people come up with a possible diagnosis of ALS, compare it to the ones that actually got the diagnosis, and so we can further refine the algorithm. And what this kind of thing does, once physicians get over the idea of using AI, that's not a small hurdle. It actually lowers the burden on the physician, not increases it, because on a big day when the patient is 21, you just can't believe it's anything serious. This kind of algorithm could change that diagnostic pathway from 18 months to a month, right? Right now,
Wow.
we depend on the person going to the right neurologist with the right connections in the right city to get them to the right clinic and the right clinical trial. We'd like to remove all of that and make it an algorithm that can use the most common EMRs.
Wow, that sounds like such a great effort. Alice, is the fire alarm off now? Yeah. I've got a question for you. Ultimately, the goal for AI is to improve patient outcomes. You bring the patient advocacy experience to our discussion today. Tell us about your experience with rare disorders and challenges you faced on the path to diagnosis and treatment.
Great. Thank you, Sean. Yeah, so I'm relatively new to this whole advocacy space. I have two young adult children. My son is 23, my daughter's 20. Both have a genetic disorder called Wilson disease, where essentially the liver is unable to process and excrete copper. Over time, it's present at birth. It's a genetic disorder. Over time, you basically reach a toxic level of almost copper poisoning that can result in extensive liver, neurological, psychiatric damage. My children, ironically, were diagnosed quite quickly, although dramatically, and that's one of the issues as well. My daughter basically presented with end-stage liver disease seemingly overnight, was diagnosed with Wilson disease. Unfortunately, her liver was so damaged that she required an emergency transplant, which she had 11 months ago and is doing well. My son, because it's genetic, underwent genetic testing and was diagnosed as well. However, I've met a lot of people in the rare disease space, and as we know, there are 7,000 rare diseases. Wilson disease is one. There's 6,999 more, and more being discovered all the time. On average, the stats show that it takes 6-7 years, 17 specialist visits to get a diagnosis. These are often very, unique, subtle or significant symptoms, often contradictory. So it's not an easy diagnosis for clinicians. And, typically you're kind of bounced around the healthcare system, seeing specialist upon specialist upon specialist, who will then refer you to another specialist. It's an enormous burden for families. Obviously, the stress, the uncertainty, expenses, out-of-pocket expenses, misdiagnoses. I know people that have undergone surgery for something that they didn't need because of a misdiagnosis. So it's a very, very challenging space. I'm trying to get a diagnosis of a rare disease. One last thing, a lot of these diseases, it's 1 in 12 Canadians, or 3 million, that are affected with a rare disorder, and often children.
So I imagine you must be listening to the other guests with some optimism, I think, based on what AI can bring to this bring to the space.
Absolutely. I think it's very exciting. I think again, the best physician in the country. I love my family doctor. I think she's great. Does she know 7,000 rare diseases? No. How could she? So I think that's where AI can be potentially very exciting to shorten the diagnosis from years to months because as Angela said, these diseases often the progression can be quite horrific, and to get that earlier diagnosis, earlier treatment, better outcomes. So yeah, I think it's very exciting because again, they're not easy conditions to diagnose.
Okay, thank you. I want to remind everyone watching the webcast, if you have questions, please type them into the Q&A box and we'll try and get to some a bit later on. Vali, you're researching and exploring the potential of AI in medicine, as you said at the outset. Tell us a little bit about your work and maybe share an example or two about some of the projects that you've been on.
Yeah, absolutely. Speaking of diagnosing rare diseases using AI, that's essentially some of the projects that I've done. Want to talk about one in particular to start with, and it's focused on this rare hereditary cancer syndrome called Lee-Fraumeni syndrome. So I worked a lot in the cancer space before kind of moving into the cardiac world, and Lee-Fraumeni syndrome was where I really started. And with LFS, these individuals have this mutation in this gene called TP53. The majority of them have this mutation, and as a result, they have this kind of lifelong risk of developing all sorts of malignancies all throughout their life, at various ages, at various parts of their body. And so with LFS, most of these individuals have this mutation in TP53, some don't. And so before we embarked on this study, it wasn't really understood why some of these individuals who don't have this mutation get this disease. The other aspect of Lee-Fraumeni syndrome is that even among these individuals that have this mutation, some go on to develop cancer, about 80%, and then there's about 20% who don't go on to develop cancer. And so that leaves the question, why are these individuals, sometimes within the same family that have the same mutation, why do some of them go on to develop cancer versus others that don't? And so what we sought to do with this project was really understand, the clinical heterogeneity present in Lee-Fraumeni syndrome. And so to do that, we used genome sequencing as well as epigenetic data, specifically something called methylation. It's these chemical modifications that occur on your DNA sequence. And in making those modifications, it leaves this pattern across your genome. And so what's really cool is that using AI, we can actually leverage the pattern that's left across your genome, across lots of different individuals, and pick up a signal that could be representative of who's going to develop cancer and who's not, at what age they're going to develop cancer and what age they're not. So one of the main goals we sought out to do was with LFS, you have individuals that develop cancer, in this pediatric phase before the age of 6 years old. So really, really young patients. And so this can obviously be very, very burdensome for patients, for the individuals that are really young, for the ones that have to undergo these whole body MRIs to look for their tumors. They have to be sedated, which can obviously be very burdensome for the patients, for their families. And not everyone lives close to a tertiary care center, right? So not everyone has that access. And so driving in, making that trek, and going through this burdensome surveillance can have, psychosocial impacts on these individuals. So if we can identify who's, more likely to develop this early onset malignancy versus those that are going to develop it later on, maybe we can customize our surveillance instead of giving everyone a one size fits all, give these these individuals who have a high risk of getting an early onset malignancy, a more intensive surveillance at those early ages. And so what we did was we developed this AI tool where you can take a blood draw, you can perform DNA methylation, and you can predict whether or not an individual is going to get a cancer before the age of 6 or not with a pretty high accuracy. And so what really this means for the patients is the ability to personalize their surveillance, their monitoring, and this is now something that we're working on prospectively evaluating. And at Peter Munk, we're really pursuing a lot of similar kind of precision medicine projects as well in the cardiovascular space. So that really ranges from like phenotyping hypertrophic cardiomyopathy, predicting risk failure, distinguishing symptomatic versus asymptomatic plaques. So I think with this kind of new advent of next generation sequencing being much lower in cost, we're able to do these really, really cool AI-enabled precision medicine projects.
Could you sort of explain actually how the AI, like in a non-technical way, like what the AI actually does? How is it trained? What is it looking for? How does it work in a nutshell?
Yeah, absolutely. So I think earlier, Sean, you mentioned, the discriminatory versus generative AI algorithm. So the one that I just described is a discriminatory algorithm. So it's trained in a supervised manner. So we know with these patients whether or not, they've developed cancer before or after the age of 6. And so what we do is we take this kind of large training data set and we say, okay, is there a pattern across these individuals' genomes that's similar, that certain regions that are maybe mutated, certain regions that are more important for their prediction of whether or not they're going to get a cancer early on. Really what machine learning is just identifying these patterns across big data sets. And that's why we're seeing, these big algorithms, these ChatGPT type large language models doing really well, because now they have these very, very large amounts of data to train on. And so for this type of supervised algorithm that I'm talking about, what we did was basically trained a model on this large data set, identified patterns that were associated with early onset versus late onset, and then we do evaluation. So one big part of training these algorithms is to ensure that we are robustly evaluating them. So we want to evaluate within our center, outside of our center, across, internationally. And so that's kind of the blocks of building an AI algorithm. Yeah.
Okay. Ricky, there's a number of early stage and developing companies in Canada that are applying AI to the healthcare space. A few that come to mind are Variational AI, Abcelera, Phenomic AI, even Clarius, which has a handheld wireless ultrasound machine, uses AI for its application. Where do you see the most progress being made in terms of startups or applications that are in market or on their way to market? Like where do you think it's going to hit first or biggest in healthcare, or is that already happening?
I think it's happening. I think here in Canada we are, especially poised for success. We look at this a lot through the lens of Continuum Health Ventures. As an early stage investor, we are lucky to have access to some of the deepest minds across academia globally. But I think the challenges that we see is that deep science projects often don't translate to commercial success. And so I think, there's some things that we're doing well and some things maybe we could do, continue to improve on that'll allow for this sort of next generation of startups to start to commercialize globally. I think from a government support and policy perspective specifically, we're often deemed to be one of the top 3 countries in the world as far as AI advancements are concerned. Examples like the Vector Institute embody how the government's, continual investment into AI research and development has created targeted funding programs and grants that encourage both basic and applied research. And I think it's the combination of the two that are going to create this next generation of companies that are going to hit the market. From a regulatory environment perspective, I think it's important that we also develop frameworks that facilitate both commercialization, but have an emphasis on ethics and responsible use. I think secondly, what we're doing well to sort of surface these companies is the startup ecosystem development in general. Incubators, accelerators, there's so many of them across Canada now. They support the creation and growth of these AI-focused companies by providing good mentorship resources, networking opportunities. CDL, I'm a little biased, was born out of the University of Toronto, Creative Destruction Labs rather, and that's a great example of this. I think we're also doing a decent job in private-public partnerships, global market access, and even export assistance. But probably where we want to spend a little bit more time from an improvement perspective is the industry academy collaborations. If we can further incentivize and encourage these types of partnerships, we can foster collaboration between academic institutions, research centers, private industries, and really bridge that gap between theoretical research and practical applications. I think in healthcare, this is specifically nuanced because the market pain point needs to be clearly addressed. And what we often see startups fail on is the inability to understand things like the differing regulatory models, depending on the geographic region they want to commercialize in. Even between Canada and the US, there are enough nuances that it makes it worthy to study those intimately. Understanding who's going to pay for this. In some regions, if physicians are not going to be incentivized to adopt if there isn't a clear path for reimbursement. How is this going to impact existing workflow? We've already talked about the existing burden to the system. Can these companies seamlessly integrate? I think the ones that are going to surface are the ones that can check off those 3 boxes. And most importantly, is this going to change patient outcomes in a significant way, such that they can, be convinced to move away from the current gold standards. I think the other things that we want to spend a little bit more time on in Canada is talent development and retention. I think from an education and training perspective, we can strengthen our AI education programs at the earliest level of education, and create initiatives to ensure a skilled workforce capable of driving innovation and commercialization. The future of work couldn't be more uncertain at this junction. I'm a little biased and a little stressed by this because I have a 7 and 9-year-old, and I think we need to prepare this next generation as early as the elementary level so they can strive in this more AI, co-pilot, autopilot world. Lastly, I'll comment on the technology transfer offices. I think between the universities and the hospitals, these TTOs have been around for a while. I think, and we've done a little program here in Toronto where we've taken some best practices from around the world to see if we can create more streamlined processes to enhance the transferring of technologies from research institutes into the private sector. I think sometimes this can be a bit of a bottleneck.
Is there a company or two in particular that you're quite excited about in terms of putting AI to use in the healthcare space?
We're an early stage venture capital fund. If I was to pick 1 or 2, that might put me in a bit of trouble. We've got an investment in a company that is aiming to solve for artificial general intelligence, which we could argue is a step further. Their thesis is that large language models on their own can only get us so far, and in order for us to achieve AGI, we're going to need to have sort of a human embodied machine present in our 3-dimensional world doing the things that humans do. And what I like about them is that their beachhead indication, this is a company out of Vancouver, their beachhead indication is really focused on the challenges of the labor force constraints today. So they want to put these humanoid embodied robots to work today to sort of solve for those problems. But you can imagine within hospital and within pharmacy, the challenge right now is that there's no limitation right now for these machines to count pills, maybe to do drug-drug interaction explanations, maybe even to do POS. And we anticipate they'll be able to do that 24/7. Sometimes we see medical error happening within pharmacy because there are challenges on any one of those 3 facets. Similarly, with hospital burnout, it could be as simple as delivering a medicine from a nursing station to a patient. We believe in the early days, these humanoid embodied forms can provide a lot of that. And, when it comes to empathy, I think it was a UC Davis study, don't quote me, that, and relatively anecdotal, it wasn't a clinical trial, performed through Reddit, that demonstrated even without a face, these large language models can outperform human empathy, human medical empathy in the order of about 4x. So I think there's a place for companies like this, and it'll allow, especially in an aging population, removal of challenges like isolation. So excited about them, but I could go on. Sean, how many should I list?
That last point sounds like fighting words for Angela. I want to hear from you next, actually. AI can be a divisive topic among physicians and care providers. Some worry it'll just be, yet another technology to get their heads around. There's concerns about privacy, data governance, the shortcomings we've already seen in great numbers from AI already. What are you hearing about from healthcare providers in terms of their enthusiasm for or trepidation about AI in the care setting, and maybe bringing your own experience and points of view as well?
So in all things, there are different personalities, even in physicians. So you get, I've seen everything from, well, I don't need that because I always think of it when it's appropriate, to people who would like to do everything with AI, right? So there's a big range. Specific to the project that we're working on, our biggest barrier in getting the next phase of the pilot study going has been the general neurologist not fully understanding that the value of, they understand it intuitively, but they are not understanding the value of having essentially an early warning system for identifying people who could be in the throes of ALS in the early stages. And part of the issue that I see, and ALS is one, I could talk about Pompe's, I could talk about Becker's, like there are many diseases like this where the diagnosis takes a while in neurology. One of the challenges that I think we're seeing is these general neurologists, just like we talked about information doubling every 7 months, they are not up to date on the treatment options that could significantly change the course of the life of the patient. And even in ALS, where we know it is fatal 2 to 5 years from diagnosis, we have at least one therapy that's just been approved in the US, and we hope to have it in Europe and Canada. We have the access to it because we were part of the clinical trial that is completely blowing that out of the water. And that's the SOD1 ALS, which is a relatively rare genetic form. It's the form that Chris White had, who was the GM of the Calgary Flames. And he was actually part of this program. And it is changing the disease so significantly that there were even a few people who actually had an improvement in strength, which does not happen in ALS.
Wow.
And their lifespan has gone from 2 years to still raising their kids, living their lives. But the general neurologist who's saying, well, it doesn't really matter because they're going to die anyway, is really not up to speed with the treatments that are making such a big difference. So that's one of the biggest hurdles that I see, is this sense that, well, it doesn't really matter. Well, in ALS, it really, really matters. And right now we are really changing the course of the disease for a number of patients. But we can only do that if those people come to us early enough, right? The other thing that I see with physicians is just feeling overwhelmed by the data out there. Like, we talked about this a couple of times. Well, I've talked about this a number of times about where to introduce these algorithms. Shouldn't you just introduce them in the family doctor office? And I actually don't think that's the right place, because family doctors are actually at the bottom catching every single piece of innovation and technology, and what we want them to do is be able to sort at the first level and send people on to a neurologist or cardiologist or whatever. So it really needs to be accessed at the right point in the system. But I think it can be revolutionary. I'm a huge fan of AI in a variety of ways, because I think it can be revolutionary in rare disease. It's also being used in one other aspect, and it hasn't come up here yet. I spend most of my life looking for drugs, not for me, but for my patients, and working on drug development. And the big innovation in drug development now is something called, well, there are 2 or 3 different names that we use, but digital twin is one name we use, and patient avatar is another terminology. Essentially, what we're trying to do, particularly in rare disease, is to create a mimic of what a normal patient what their normal trajectory is, so that every patient in the drug development program gets the drug. So it eliminates the concept of a placebo-controlled trial. And that's another application of AI where this is not really the forum, but it's incredibly exciting. I think Rick wants to say something.
Yeah, I want to go to Alice next, but Rick, you wanted to make a point.
Yeah, just a quick comment on Angela's point on, where can we sort of insert this? We often use the term homespital, and I think the idea here is that our home is where we live, breathe, eat, sleep. It's a digital exhaust, and I think as we get more sophisticated with ambient listening, and that can be from voice to machine vision, I think, and more, I think the first point where we should start to implement this, and Vali talked about wearables, of course, those are valuable as well. I think we should allow and we should empower the patient to start to capture some early information. This should all be part of the longitudinal patient journey. They should have a clinician co-pilot that should be supporting the outputs of any of the generative or non-generative models. And I think we should be there earlier. I think once it gets to the specialist, in many cases, it's too late, or it becomes much more complex to reverse. So I would advocate for more of this in the home and on our bodies.
Alice, I want to ask you, sort of continue on the discussion about where your hopes, how AI can help patients and families, but also about some of the risks. And some of our viewers are asking about the AI risks and potential downsides. Is that something you've thought about or experienced?
Well, yeah, and I think one thing we all need to keep in mind is, the patient is the center of all this. So, that needs to be front in mind first and foremost. I mean, I think it's very exciting, not only in terms of diagnosis, but potentially treatment options, development of new drugs. Many of these diseases do not have any treatment options. So once you get this devastating diagnosis, you're just waiting for the inevitable disability or fatality. So certainly exciting, again, from a research perspective. I know for Wilson disease, currently the estimation is 1 in 30,000 people, but they think it actually may be higher. We just haven't really captured the data about all these diseases. And the patient populations are so small, they're small data sets. So again, AI is exciting. I think, the risk is, again, data breaches, security, transparency, patient privacy, confidentiality. I think it's probably pretty exciting to get caught up in all the data and the possibility. And I think, there needs to be an awareness that this is patient data with real life people. So, we need to do our utmost to protect that and understand how it's being used.
Well, can you tell us a little bit about some of the shortcomings and challenges? Is there enough data, for example, on all these rare diseases, or we've heard issues about privacy and governance. I mean, as someone who puts this into play, what's informing the work you do, you and your colleagues do, and what are the shortcomings or the things that AI can't do, or that where there's still a gap, what it could do, what people hope it could do in terms of applications to healthcare?
Yeah, Sean, we've come a long way, but I think you bring up great points, and Alice touched on a little bit about it as well. That these algorithms are not without risks, and especially in a healthcare setting, which is a really high stake setting. We don't really have an infrastructure in hospitals for operationalizing AI. So this includes even just from the resource perspective. I know Ricky mentioned, it's really important that we partner with these private companies so that we can actually power these AI technologies. That's really important because a lot of hospitals don't have the resources for, inference, these GPUs, the storage capacity. And so, these companies do. And so by powering, working with them, we can actually be able to operationalize AI. Another big aspect of it is being able to robustly evaluate and monitor these AI systems. It's one thing just to have an AI algorithm and then implement it in the clinic, but you actually need to be able to monitor it, make sure it's performing as it's expected to perform. And if it's not, then we need to intervene. And so we've done a lot of work in this space, something called data shifts, And it's the idea that, you implement an algorithm, or the data that it's trained on, it doesn't match up with the data that it's being evaluated on during deployment. And this can occur across various different axes. It could be due to differences in patient demographics. It could be due to, catastrophic event, COVID-19 just happened. It could be due to changes in medical devices, EHR systems. And so ensuring that we actually evaluate for these data shifts to ensure that our models are performing as expected is really important. And then you also mentioned privacy and security. For rare diseases, especially, it's really important that patient information is confidential for any disease. But for rare diseases, it's really easy to actually identify these patients just by knowing that they have this disease, right? So for diseases like Leaf-Fermeni syndrome, you know that there's only a handful of people in the city that have it. If you know that person has it, you can easily discriminate against that person based on the fact that they have that. So it's really important that these measures are in place. In terms of acquiring these really large data sets, that takes time. And even for our studies, it really takes a community-wide collaborative effort to get these patients to come forward, to provide samples, to have the resources to sequence them, to collect their data. And then over time, we will be getting these larger data sets. And we're seeing that happen over the years. Now we have, as I mentioned earlier, these large databases like UK Biobank, All of Us, HostSeq, like these large databases with thousands of patients. And this is only going to grow. And then the last thing I really want to touch on is, a lot of AI leaders have really talked about these kind of existential threats that are posed by AI, where AI leads to this like dystopian world where machines are taking over these systems and they override human control. But I think what's often failed to be mentioned is the real and more imminent risks of AI, which is the risks of AI encoding these structural inequities that permeate these century-old legacy systems. And this would only further amplify bias and exacerbate these disparity gaps that in critical areas like healthcare. And so for these communities that are historically disempowered and disenfranchised, those are the ones that are most at risk for these AI algorithms not performing as they should.
Okay, I have a question I'm going to throw to Angela, and then I'm going to come back to you, Ricky. There's an audience question, Angela, about dementia and Alzheimer's. Are there AI applications to detect and treat those early? Maybe you can talk about other neurological disorders where you're seeing AI being applied as well.
So I actually thank you for the question. I actually think that there's another AI company that's actually working on exactly that. What distinguishes the worried well from early dementia, and tries to sort the different signs. It's in its infancy. And interestingly, for me as a neurologist, in fact, Alzheimer's is in some ways easier to identify because some of our tools are things that can be turned into apps. They're used by family docs, they're used by physios and many different people in the system. But more challenging is actually other forms of dementia. There's something called frontotemporal dementia, where there are therapies that are actually already developed, but because we're having trouble identifying these people early, they're not getting an opportunity to participate. So AI is being focused on the dementias, more success in Alzheimer's than in some of the other rarer conditions where it's actually going to be more valuable. And I just, one of my thoughts as I was hearing Valley was, for those of us of a certain age, people said that once TV came, radio would disappear, and radio is never going to disappear. So some of the people who are fearful of AI will come along as AI finds its place in every discipline, and it will find its place, and old and new will fit together. So it's just part of our job as innovators in our fields to help people deal with that fear, so that we can get the data lakes and the access to data, particularly in healthcare, that are going to help these tools really support a better healthcare system.
Okay, Ricky, we have an audience question I'm going to throw to you. How are AI tools related or connected to electronic patient records? Is there a way to gather or share data without compromising patient privacy?
Yeah, sure. For years we've been looking at AI companies, and one of the challenges that they have is they don't have access to clinical data or enough clinical data for it to be robust. And with the changing landscape of the FDA's perspective, and we're seeing the same thing in Europe now, heterogeneity of that underlying data is also important, especially where you live in regions where the population is highly heterogeneous. And Canada is a great example of that. So, company after company, we had to turn them away because the bottleneck was they couldn't get access to the relevant amount of information to train their algos. Subsequent to that, we started looking for companies that could solve for that problem. Historically, we've seen de-identification be approach. Valley's already uncovered a challenge given AI, given social media, and given some of the situations that we associate with rare disease. But even beyond now, the ability to reverse engineer de-identified data is proving to be a bit of a challenge. Synthetic data kind of arose as an interim solution. I think we're still determining how good that can be. I have my personal concerns with it. So we found a company that has the ability now to create non-de-identified data and share it from the data stewards, which are these hospitals. And that could be, pediatric facilities collaborating collectively on rare diseases, and create, in essence, a zero trust enclave, a handshake between these data stewards and this very sensitive data and the AI companies that want to test and validate their algorithms on it. The data never leaves the cloud prem of the hospital or the system, and the algo developer never actually sees the data. They simply get a report on how their algo is performing against that data. I think this is really important. Although we have a big focus in the United States with some very large health systems right now, I'm pushing in Canada to try and see if we can get this across the board. I think this will open up data. I think this will, to answer the question of the audience member, I think this will allow algo developers to now gain more access, more heterogeneous data, the stuff that the regulators want to see to prove out their hypotheses.
Okay, Alice, I have a couple of questions for you. A risk with AI and new technologies is that they develop without adequate input from patients or their supporters. Do you see companies engaging patients and family members, advocates? Is this happening, and to what extent from your experience?
To be honest, I don't have a lot of direct experience, but yeah, I think there is a lot of interest, and it's such an explosive field, and I think for a lot of patients and health advocates on the front line, there's maybe sort of low or limited awareness about it. So I do think you have to be very, very careful about companies potentially taking this sort of patient data and trying to monetize it or commercialize it. So I don't really have a lot of experience with that, to be honest.
Okay, Angela, you wanted to make a point? I want to come back to you for something else, Alice, but Angela?
So there's a group, it's a not-for-profit called Everything ALS, which actually has volunteer patients. Patients volunteer, a huge uptake internationally in volunteering, and they're really driven by using AI to improve our monitoring of patients with ALS. So the PALs, which are patients with ALS, volunteer to be involved, and they share their data, their own data, and they get involved in the various new digital devices, digital outcome measures, digital biomarkers, and that is a model. It's one that we haven't brought to Canada yet, but we're talking about it. But what I found is that at least in ALS, you have a tremendous interest in the patient community to actually engage really early in these AI programs. And so the patients are ahead of the physicians often.
Interesting. And actually to Valley, could you talk about, like, when you're doing your work, are you seeking out these views, or are they coming into you?
Yeah, I mean, we do integrate, the patient experience. I think we can obviously always be better at that, but I think even with AI and having this large role in healthcare, it's really important to still take a holistic care approach. At the end of the day, an AI algorithm is not going to replace a clinician. It's not going to replace, the human touch. And so there's aspects of that that needs to be maintained. And I think these algorithms going forward, we need to ensure that they take this feedback, and there is this continuous feedback loop between AI, patients, clinicians, in order to really maximize the efficacy of this and prevent the risks. And so in doing that, a big aspect of that is providing the proper training and education. And so I think Ricky also touched on this, and the idea of like having these training and education in medical schools for patients in the healthcare system as a part of the system, not just kind of an add-on, as we now see that AI is really going to be integrated in healthcare, and it's not just kind of the supplementary thing anymore. It is, going to be a core element, and so there should be these foundational skills that are developed in these individuals that are a part of this system.
Okay, Alice, I want to come back to you. I was quite struck when you said that I think 3 million Canadians have a rare disease. I mean, that's nearly 1 in 10 people. There's probably a lot of people watching the webcast now who have that experience. Maybe they're starting that journey. I was wondering if you could just share some leaving aside AI for the final words here, some advice or thoughts you have for patients or their family members to support them on navigating the rare disorder diagnosis journey. I mean, do you have any thoughts, any helpful advice for people?
So I would say don't be afraid to step out of the shadows. I feel that I always say rare isn't that rare. It's 1 in 12. It's 3 million. There's more awareness about it, which is great. The federal government earmarked $1.5 billion for a rare disease drug strategy. That was announced in March 2023. We need to turn that from a strategy into concrete action plans. They need bilateral agreements with provinces and territories. We're still waiting on those. I think we need more advocates in the rare disease space. I would love to see a spot in the healthcare system where we carve out or create, a rare disease center of excellence, or maybe it's around different rare disease clusters. I think, some of the amazing work that's been done with cancer, with diabetes, with cardiovascular health. I would love to see, again, sort of a dedicated space for rare diseases where we can look at AI, drug development, treatment options. I think too often in the past, patients have been bounced through the system because the system is like, it's difficult. It's not easy. So I would love to see more people involved in the rare disease, pressure government. We need those bilateral agreements with the provinces. And there's $1.5 billion waiting to be funded across the country where we could get more, standardized treatment, standardized care. So rare, I think, is almost a problematic word. Rare, I think the meaning is it affects less than 1 in 2,000 people. So yes, maybe it is small patient populations, but collectively, it's 3 million Canadians, and a lot of them are children. So let's put that emphasis getting the diagnosis and treatment before it's potentially catastrophic. And think about, the savings for the system. So learn more about the rare disease strategy, the drug strategy, the wider rare disease strategy. Let's carve out a space in the system.
Well, that's what this is all about, and you've left us with some great food for thought. Thank you. Thanks to all of you. We'll leave it there. This has been a really terrific discussion. I hope all of you watching this feel the same way. On behalf of the Globe and Mail, I'd like to thank Angela, Alice, Ricky, and Valley for being here today. And also would like to thank a special thank you to our sponsor, Mitsubishi Tanabe Pharma Canada, for making today's event possible. And of course, thanks to all of you in the audience for tuning in. We'll send a link to the recorded webcast to all of those who registered in about 2 weeks. Thanks again. Enjoy your day and have a great holiday season. Thank you.